lunch, but we also want to share with you on our presentation here. So we hope that you will not be distracted much, that you will still give us your attention as well. A quick commercial. It's always good to start on a commercial, right? At the registration desk, you may have seen some of these postcards. This one says Ashra. Pick one as you leave. It's on Adventist Health Researchers Association conference coming up at Andrews University later this month. There is another postcard. This is on Andrews Autumn Conference on Religion and Science coming up in November 7th to 9th. And thank you, Dr. Grace. ABC next year at Andrews, right? Go AU, right? That's right. Thank you very much. My name is Mordekai Ongo. If you hear the beautiful accent, it's because I'm not giving it up. It's from Kenya, right? So welcome to Berrien Springs, and you will enjoy what we got at Andrews University. I work in the Office of Research. My boss, Dr. Kereri is here, and my provost is here, and also my good friend who has helped me to go through ethics, Dr. Duane Kovrig, is also here. And thank you, Grace, for this opportunity. I will be presenting today. I work in the Office of Research as a Research Integrity and Compliance Officer for Andrews University. I also serve as one of the 4 ombudspersons at Andrews University, and the third hat, adjunct faculty. So it's a beautiful combination right there. I'll be presenting with my friend and a fellow Kenyan.
Hello. I know that this is the best time. I'm trying to move away from the reflection there. I know that this is the best time to connect and talk and chat. But unfortunately, we didn't arrange this, so you can't blame us that we are doing a presentation when you're supposed to be eating. Anyway, my name is Dovison Kereri. As you can see here, I am the director for the Occupational Therapy Program. And I know that my chair, Dr. Ferrari, she's sitting back there, my colleagues, De Leon, and of course my provost, and several chairs from Andrews. I'm really excited to be part of this presentation. And I'm just kind of looking at, we need to talk about compassion. Compassion. And the central theme is based on Colossians 3:12, which really says that therefore, God's chosen people, holy and dearly loved, clothe yourself with compassion. Clothe yourself with compassion. Then he goes on to give a few, kindness, patience, and all these things. So our presentation, we wanted to put that intersection between compassion and patient satisfaction and how it links to reimbursement and prevents provider burnout. I think, so we will go through the introduction, look at how patient satisfaction scores and reimbursements. Then we look at the SERVPERF perspective, that is the Service Performance Assessment Metrics. We'll also look at compassion as a stabilizing force. Then briefly go through provider burnout.
And because of time, we may not be able to exhaust the information we have on those 20 slides within 15 minutes and maybe 5 for Q&A. And so we will be going very fast, but we hope you will be able to benefit. In this world of competition in healthcare organizations rely on metrics to help assess patient satisfaction with the quality of service and their perceptions to be able to link that to reimbursement for the services that they offer. But as we go through this, we will be leaning more on the side of not making, as important as money is, that we focus probably more on compassion and then see the hallmarks of compassion thereafter.
So the key, being in the same environment where each and every provider has the same value, thin margins, stiff competition, increased technology. So what would stand out for us to make sure that we are the identity, we are the preferred provider? So that's why compassion comes in. And how do you intersect that compassion? The Centers for Medicare and Medicaid Services, which the CMS, they implemented the Consumer Assessment of Healthcare Providers and Systems, which is a survey that is sent to the patient to assess their patient satisfaction in the service that they're receiving. So out of that survey, then CMS is moving to the point where they will be reimbursing people based on the value-based purchasing program. And this is really driven, or this is a driver trying to improve the quality of care that the patients receive. So those surveys, they're also scored and recorded to be able to provide even the managers, the administrators in this facility to be able to look at how they are doing. And this was an initiative that was initiated in 2008.
SERVPERF is one of such metrics that is used to assess patient satisfaction, quality of care that they receive. And this particular metrics has been used in a variety of multiple service institutions, right? Whether it is in higher ed or healthcare or credit card. It's been used. The idea is to assess the perception of the patient. How do they perceive the service or clinical care that they receive? SERVPERF service performance, therefore, is used and has been used in healthcare. I would just want to walk you through the 5 dimensions that are used in determining their perception. One is reliability. In other words, the employees' ability to perform the promised service when they walk into the facility. Are you delivering what you actually indicate you will be able to deliver? Number 2 is responsiveness. The employees' willingness to help patient and provide, help patient and provide prompt service. How are they perceiving that? Assurance is the ability of the institution and the employees to convey trust and confidence. Very, very important. And of course, patient and everybody else in service, sometimes, according to SERVPERF, people look at the tangibles. What is the state of the equipment that is being used to deliver the service, whether it's clinical or otherwise? They look at the appearance of what they see, the things that are tangible. Remember, service is not tangible. It is something that you experience, even in healthcare. So experience of the patients is key, is critical. SERVPERF has the last dimension of empathy, that element of caring and providing individualized attention. Remember, the important call is to serve others with love, with compassion, and to show, just as in our Advent group, that we value human dignity and equity, and that compassion, therefore, should be the stabilizing force in our healthcare provision.
So, moving back to that Colossians 3:16 that says, therefore, as God's chosen people, holy and dearly loved, clothe thyself with compassion, kindness, humility, gentleness, and patience. So if we are all sitting in the same environment, all these healthcare providers have access to the same service that they could get somewhere else. So what could make us unique? Why do you want them to come to you? Because they can go anywhere else and get the same service. So that's why we move that in this environment, the unique thing, the driving force should be compassion. Compassion should be the driving force. It should be the one that would move those clients from coming to you. Because otherwise, if everybody provides the same service, then why should they come to you?
And so we say that based on the Colossians 3:12, even if we were to, parallel that to SERVPERF, as Adventist healthcare providers, we probably should create that culture in our service. So if a patient walks in, what is their experience with the billing department, for instance? Do they see Colossians 3:12 says, therefore, as God's chosen people, holy and dearly loved, clothe yourselves with these attributes: compassion, kindness, humility, gentleness, and patience. We are thinking that we could actually develop a metric that is built on those elements. And that would help us to understand how our patients perceive the service that we offer. And it is important. Of course, I would say, give us some grant somewhere and help us, because we want to take this beyond just that one element of compassion and include the other four in creating a metric that would actually benefit us in knowing our identity as we build that culture within our healthcare system. Those things are not aligned directly. They are randomly written. Of course, the first set on Colossians, those come in that order. But we will be looking at the definitions of compassion. The idea is, can we create a culture for our identity?
As you are going to notice, is that we are putting a lot of this Colossians 3:16 almost every slide that we go to. But we wanted to emphasize the fact that we are God's chosen people, truly loved. And then, what is really compassion? We really wanted to make sure that we can define compassion. Compassion is an emotional response with a strong desire to help. So most patients, when they walk into the room to see you as a provider, as a healthcare provider, they come in with some pain. Could be physical, emotional. But why are they coming to you? They're coming to you because they need help. And you, as a provider, going to them with that strong feeling, an emotional attachment with a desire to help. So it's a motivation or an emotion or a virtuous response that is often related to the service these people receive.
An example of a model of how that would look, those two circles. On one side, we have the healthcare provider, and on the other side, we have the patient. The most important thing is at the intersection, the interactions that are going on between the provider and the patient. Those things include things like communication, how they perceive whether you listen to them, whether you actually show your presence in a loving care for them. Those whatever takes place within the intersection is key. You download our PowerPoint and read whatever is in the middle. It's key in developing that culture of compassion. And I will skip that and listen to that story.
Well, like I said before, I'm an occupational therapist. I've been practicing for the last 30 plus years. I've had an opportunity to provide care through various continuum of care. I've been in several systems. I've worked in other institutions where the Bible, prayer is not welcome. I've been in other institutions where prayer is encouraged. So I worked in one of these systems. I may not name it. I guess if you look at my resume, you might identify them. But it was a Catholic institution where I worked. they welcomed prayer. They said, prayer, prayer, prayer. If a patient comes in and they want to read the scripture, pick up the Bible and read for them. So one day I walk into ICU. This patient had been in event for three months. And I just walk in the door. The first therapist, I believe I was the first therapist to walk into ICU after the event. And this patient turns around to me and says, sir, could you please pray for me? You know, and the first thing I did, I looked around the room to see whether I was carrying a pastor patch or a Bible with me, and I couldn't find one. But anyway, I said, this is an opportunity to express my faith and my calling to God for this patient of mine who needs prayer. Maybe this is the last prayer that he needs for healing. So anyway, I prayed for him, and got done, and we said amen. I didn't do what the speaker in the morning, Peter, was saying that I should have asked him what they wanted to pray for, but I just prayed for him. I knew he was in the event. I had read about his history. I knew that this patient has been sick for 3 months in ICU on event. That's really a long time. So I prayed for him. When I got done, he said, oh, sir, thank you very much. I knew you could pray. I knew you could pray. So, and I was like, okay, so how? He said, you walked into the door, I felt like you could pray for me. So I prayed for him. He was moved out of the ICU, moved to the cardiac floor. We continued to see him through the cardiac floor. He moved to the inpatient rehab, continued to see him, and he wanted to continue connecting with me. Out of the rehab to outpatient, he was coming to see me. He was healed, finally went home. We continued to have that friendship for several years. He used to just stop by in my department to just say hi. I felt sorry that at some point we lost touch. But I looked at it, I was like, you know what? What really touched this connection? When we provide compassion, when we connect with the patient, then it makes us have that emotional connection, a response, a desire, a strong willingness to help. So if we have that motivation and connecting with these people, as we continue with this, and I think this would connect to the point where we are talking about the connection with the reimbursement. If you have a connection, then there is a response in that patient himself with a repeat consumer response. So they'll come back to you again and again.
And we will not be able to go through all our slides because of the interest of time, but just take a quick look at the hallmarks of compassion. You must have that strong desire to help. You have to have the ability to collaborate, to communicate, and to partner, walk along the suffering with the patient. You have to have a commitment of all who provide and support the healthcare, and also have well-being and resilience of healthcare professionals. Dr. Dovison, we just ran out of time, I think. We were supposed to finish at what, 12:55? Unless we have grace, but we take time, download our PowerPoint, and look forward to, we'll hopefully get a publication out of this as we continue to engage. Thank you so much. Does anybody have a question or an input? I think just 1 minute. Anybody?
Any questions?
Otherwise, thank you very much.